Hello, this is a review on a journal article by Giuseppe et al. From the American College of Obstetricians and Gynecologists. The title of the article is Timing of Delivery and Adverse Outcomes in Term Singleton Repeat Cesarean Sections. Our presentation will be structured in the following manner. We will begin with an introduction which will give the rationale behind the writing of the paper, including past research papers. We will then discuss the methods and results of the paper, followed by a brief discussion about the results according to the authors of the paper. We will then briefly critique the paper, highlighting what was done and what could be improved upon. Lastly, we will submit a list of recommendations for future research regarding optimal timing for elective repeat cesarean section. The purpose of the paper was to determine the optimal timing for elective delivery in term singleton repeat cesarean section. The emphasis here is on repeat cesarean sections. The author's rationale is that prior studies have shown a higher risk of neonatal morbidity for deliveries before versus at 39 weeks. These include such conditions as hypoglycemia, neonatal ICU stay, neonatal sepsis, and neonatal respiratory illness. The authors want to determine when is the optimal timing to deliver the fetus by comparing the risk of delivery at specific gestational ages to the risk of delivering at a later time. This is to parallel clinical decision-making in the real world, where clinicians are faced with the choice of delivering now or expectantly managing the mother. The importance of the findings are that there is an increased rate of cesarean section in primiparous women, some of these women being at low risk for vaginal delivery. These women may then opt for repeat cesareans in future pregnancies, hence the risk of repeat cesareans and the optimal timing are important. Secondly, there is also an increased rate of requests for elective repeat cesarean sections according to trend studies by other papers. Lastly, the authors wish to determine an ideal timing for repeat cesarean, taking into account current knowledge regarding benefits of delivery before and after 39 weeks. Regarding the earlier points, as of 2003, the cesarean rate for primiparous low-risk women in the United States was 23.6%, and for all primiparous women, 27.1%. Also, the authors noted that there was an 88.7% rate for repeat Caesars in low-risk women in the US from 2003 to 2006, and a rate of 89.4% for all women for repeat Caesars from 2003 through to 2006. The authors also felt the need to compare the benefits of early versus late-term cesarean based on current knowledge. The benefits of delivering before 39 weeks, otherwise viewed as the authors as an early-term cesarean, include the avoidance of stillbirth, the fact that there is less risk of fetal compromise from uteroplacental insufficiency, as when the pregnancy progresses, the placenta becomes less able to fully meet the needs of the fetus. Also, the benefits of delivery before 39 weeks include the removal of the fetus from a possibly hostile uterine environment, the resolution of underlying conditions before secondary symptoms develop, as in the case of preeclampsia and gestational diabetes. Also, the authors hypothesized that this could also avert emergency unscheduled cesarean deliveries, where such complications as uterine rupture could occur. The benefits after 39 weeks include that the fetal lungs will have reached maturity, and there has also been found to be decreased neonatal morbidity and adverse outcome in 39 weeks compared to 37 weeks delivery. The study is a secondary analysis of a dataset taken from the Cesarean Section Registry of the Eunice Kennedy Shriver National Institute of Child Health and Human Development Maternal Fetal Medicine Units Network. The deliveries are performed at 19 U.S. academic centers over 3 years from 1999 to 2002. 4 groups are taken from this dataset for the study. They are indicated with labor, indicated without labor, elective with labor, and elective without labor. So, if you take a look at this diagram, the total number of patients in the dataset were 378,063. Of this, those termed singletons with history of cesarean delivery were chosen, and the number was 23,794. This group is then subdivided into indicated and elective. The paper did not specifically state what constitutes indicated and what constitutes elective, but from the previous paper the study referenced, it was stated that indicated includes prior classical or inverted T incision, breech or transverse presentation, placenta previa, prior myomectomy, non-reassuring patterns in the antepartum fetal heart rate, and genital herpes. These 2 groups were again subdivided into those with labor and those without labor. The primary outcomes analyzed for the study were composites. The composite maternal outcomes used for this study are stated on the left, and the composite neonatal outcomes used for the study are stated on the right. Maternal outcomes included death, pulmonary edema, cesarean hysterectomy, pelvic abdo-abscess, DVT or pulmonary embolus, pneumonia, and blood transfusion. Perinatal outcomes included in the perinatal composite included death, respiratory distress, transient tachypnea of the newborn, necrotizing enterocolitis, sepsis, mechanical ventilation, seizure, hypoxic ischemic encephalopathy, NICU admission, and a 5-minute APGAR score of less than 4. The study compared the composite outcomes of those in the group elective without labor for a specific week with the composite outcomes of all the deliveries after that specific week for those in the other 3 groups. So to further illustrate, if you take the top row of this slide, the outcomes of those delivered at only 37 weeks and only in the group elective without labor were compared with the outcomes of those beyond 37 weeks, that is weeks 38, 39, 40, 41, and 42, and who are not delivered electively without labor. This comparison is done for every individual week from weeks 37 to 41. And so to further clarify again, if you take a look at the last row of this slide, the outcomes of those delivered in week 41 and in the group elective without labor were compared with those in weeks 42 and in the groups elective with labor, indicated with labor, and indicated without labor. I will now talk about the study results. In the top diagram, the solid black line represents the percentage of composite adverse maternal outcomes when electively delivered at a particular gestational age. The dotted line represents the percentage when patients were expectantly managed. The first graph shows that the lowest risk of poor composite maternal outcome is when there is elective delivery at 39 weeks. The second graph, which features neonatal outcomes, shows that the lowest risk of poor composite neonatal outcome is when there is elective delivery at 39 and 40 weeks. Based on the two graphs, the conclusion was that elective cesarean delivery at 39 weeks is best for both maternal and fetal outcomes. Why perform an elective cesarean section at 39 weeks specifically? After all, beyond this time, composite maternal outcomes in elective cesarean deliveries are lower than when patients are expectantly managed. The reason is that although adverse maternal outcomes reach a nadir at 39 weeks, the risk rises by more than 50% at 40 weeks and beyond. Conversely, from 39 to 40 weeks, the risk of poor neonatal outcome decreases proportionally less by about 10%. Hence, 39 weeks is taken to be the ideal time for both mother and the baby. Moving on to the specific outcomes, elective cesarean delivery at 39 weeks was associated with lower maternal and neonatal outcomes than in expectant management. Maternal outcomes included a lower risk of blood transfusion and cesarean hysterectomy. Neonatal outcomes included a lower risk of sepsis, death, respiratory complications, and ICU admission. In summary, in the absence of specific maternal or fetal indications for earlier delivery, the paper recommends elective repeat cesarean delivery at 39 completed weeks of gestation as the optimum elective delivery timing for both maternal and fetal outcomes. The authors of the paper concluded that there was improved maternal outcome with delivery at 39 weeks. The improved maternal outcomes were found to be decreased need for and amount of blood transfusion and the lesser hospital stay of more than 5 days. They postulated that this is due to the development of the lower segment in the latter part of pregnancy at 37 to 39 weeks, which leads to improved surgical access and decreased vascularity. They have also found the risk of maternal complications to be of this order. Emergent and in-labor cesarean section is associated with the highest risk of maternal complications, followed by elective cesarean section, and lastly, with spontaneous vaginal delivery having the smallest risk of maternal complications. The maternal complications they looked at were uterine rupture, deep vein thrombosis, and anesthesia-related complications such as failed intubation and aspiration. As such, they concluded that in an event of unlikely normal vaginal delivery, one should always opt for elective C-section at 39 weeks. The authors also raised a possible confounding factor to the study, as the lower rate of complications can also be due to decreased number of cesarean sections at 39 weeks due to an increase in the number of normal vaginal deliveries both at and before 39 weeks. However, their findings were consistent with American and European cohort studies, which showed increased neonatal morbidity and mortality with elective cesarean delivery before 39 weeks of gestation, and elective deliveries at 39 and 40 weeks of gestation being associated with fewer adverse neonatal outcomes than is pregnancy continuation. The sudden death of a fetus in utero has tragic complications, especially when the alternative could have been a healthy neonate had delivery occurred earlier. Thus, there is a need for future studies to further validate this work, as current theories seem to suggest otherwise. Other theories include that there is a risk of unexplained stillbirth, which increases after 37 weeks gestation, and early deliveries can prevent complications of uncontrolled gestational diabetes mellitus, gestation-induced hypertension, and preeclampsia. Thus, the need for future studies to further validate this work. This slide depicts our critique of the study. The patient population selected was large and represented many academic centers in the US spanning over 4 years. The authors compared multiple factors such as different gestational ages, the absence or presence of labor, and indicated or elective cesarean delivery. These points made the study comprehensive. However, they failed to define the reasons for indicated and elective cesarean section, which may have an impact on maternal and neonatal outcomes. Patients who had existing diseases such as asthma and diabetes were included in the study without differentiation from healthy mothers. The severity and nature of maternal disease will most certainly influence the outcomes for both mother and child. There was also no differentiation between patients who had had 1 or 3 previous cesarean sections. The reasons for their previous cesarean sections were also not mentioned in the paper, making it difficult to account for underlying maternal health or pregnancy-induced complications. In the analysis of their results, the authors compared outcomes from elective cesarean section without labor with the 3 other groups. This was based on a study design by a different paper in 2007, in which the risk of uterine rupture under various conditions was investigated. However, in this study, the same comparison is not a fair one. Instead, the authors should have compared outcomes at different gestational ages within each group, as illustrated on the next slide, so as to control for pregnancy-related complications that are different in each group. As mentioned in the previous slide, the authors should have compared elective cesarean without labor, as is evidenced in the red box, at different gestational ages. This would have been a fair comparison. Similarly, the authors could have chosen to also compare elective cesarean with labor at each of the 6 different gestational ages. This would also have been a comparison that was fair. The authors compared the outcomes at each gestational age with those of more advanced gestational ages. For instance, maternal and neonatal outcomes at 38 weeks was compared with those at 39, 40, 41, and beyond. A more appropriate approach would have been to compare outcomes at each gestational age with those at all other tested gestational ages. For example, 38 weeks would also be compared with 37, 39, 40, 41, and beyond, instead of 38 weeks just being compared to 39, 40, 41, and beyond. In using composites of maternal and neonatal outcomes, the authors were able to analyze numerous morbidities in a single study. However, by combining various outcomes into a single composite, the true risk of each morbidity is masked. Finally, the risk of stillbirth was excluded from the study due to the lack of cases. This is a true weakness of the paper, as it is known that the incidence of stillbirths increases beyond 37 weeks gestational. In summary, starting from the top left-hand corner of the slide, there is an increased rate of requests for elective repeat cesarean sections. For this study, the research group compared across 4 groups over different gestational ages, 37 through 41 weeks. It came to a conclusion that elective repeat cesarean delivery at 39 weeks gestation is optimum, where maternally there are lower risk of blood transfusion and cesarean hysterectomy, and neonatally there are lower risk of sepsis, death, respiratory distress syndrome, transient tachypnea of the newborn, and ICU admissions, just to name a few. However, what tips the balance are certain areas which we find needs improvement. This was covered just now under the critique section. Examples include the use of composite maternal and neonatal outcomes, the comparison of elective cesarean without labor versus all others, the reasons for previous cesarean sections not being given, and last but not least, the definition for indications of cesarean section. We would like to recommend a new study which is more focused to compare elective repeat cesarean sections without labor across gestational ages. With this, it would be good to firstly define composite outcomes and its severity. Secondly, define indicated and elective cesarean delivery. Next, to exclude patients with existing diseases or indications for early delivery. Hence, we would have a more stringent inclusion criteria. It would also be good to specify the reasons for the prior cesarean delivery. And lastly, we would include a larger range of gestational ages. Thank you for listening to our presentation. We hope that it was informative. At this point, we would like to thank Dr. Sonali for her guidance and mentoring us in the critique of this paper.